So good morning or good afternoon, everybody. On behalf of the Canadian Federation of Mental Health Nurses, the Canadian Federation of Nurses Unions, and the Canadian Nurses Association, I'm honored to welcome you to the first session of our national three-part webinar series focused on one of the most pressing issues in Canadian healthcare today, supporting and sustaining the mental health and wellness of our nursing workforce. My name is Dr. Don Lytle. I'm the current president of the Canadian Federation of Mental Health Nurses, and I'm going to be the moderator for today's session. Before we begin, we acknowledge that we're all on the traditional, ancestral, and unceded territories of Indigenous peoples across Canada. These lands have been stewarded by the First Nations, Inuit, and Métis peoples for millennia. We recognize their enduring connection to this land and express our gratitude for the opportunity to live, work, and learn here. This acknowledgement is a step towards reconciliation and a commitment to honoring the histories, cultures, and contributions of Indigenous peoples. We encourage everyone to share in the chat where they're joining from today as well. Across the country, nurses and healthcare workers are experiencing a silent mental health crisis, and the COVID-19 pandemic has only exacerbated these challenges. Staffing shortages, lack of resources, moral distress, and increase in workload are everyday realities that contribute to the stress and mental health challenges healthcare workers face. This silent mental health crisis and the understanding that we as national organizations have a role to support our healthcare workers prompted us to come together to bring all of you resources, tools, and stories to support you. 3 nursing organizations, the Canadian Federation of Nurses Unions, the Canadian Federation of Mental Health Nurses, and the Canadian Nurses Association have come together with Dr. Lee Chapman, the Chief Nursing Officer of Canada, to address a major theme within the Nursing Retention Toolkit: improving the working lives of nurses in Canada, organizational mental health and wellness supports. Today's session will set the stage for deeper dives in 2 subsequent webinars, with one on June 25th, 2025, hosted by the CNA, and another in September 2025, hosted by the CFNU, and offer attendees the opportunity to engage with the teams behind their work. I'm delighted to introduce 2 exceptional presenters today. Kamlesh Tello, a manager from the Prevention and Promotion Initiatives of the Mental Health Commission of Canada, is our first presenter. Kamlesh brings over 20 years of experience in improving healthcare services at the system and organizational levels across the continuum of care. She has worked in hospitals, government, and healthcare consulting. At the MHCC, Kamlesh's focus has included the development of the Quality Mental Health Care Framework, psychological health and safety for healthcare workers, structural stigma, and culturally adapted CBT. Kamlesh has also a Master's of Science from the University of Toronto. Our second presenter is Dr. Melissa Corrente, Senior Research Associate with the University of Ottawa. Melissa is a proud member of the Canadian Health Workforce Network, and she's passionate about researching healthcare worker burnout and providing evidence-informed interventions that target organization and system-level change. Dr. Corrente worked alongside a team of experts to curate and develop a bilingual health worker burnout toolkit and a psychological health and safety toolkit for primary care teams and training programs. She is currently involved in a CIHR-funded research project focused on building psychological health and safety in long-term care. Together, they'll walk us through the evidence and intention behind these tools and share practical ways organizations can integrate them into their daily operations. But before we get into the presentations, there's a few disclosure statements that need to be made. This webinar received in-kind support from the Canadian Federation of Mental Health Nurses, the Canadian Nurses Association, the Canadian Federation of Nurses Unions, and the Canadian Health Workforce Network, the Mental Health Commission of Canada, and Health Canada, all in the form of staffing resources. The CHWN and the MHCC developed the Open Access Psychological Health and Safety Toolkit for primary care teams and training programs that will be mentioned in today's webinar. The Psychological Health and Safety Toolkit was part of Team Primary Care, an initiative of the Foundation of Advancing Family Medicine, co-led by the College of Family Physicians of Canada and the Canadian Health Workforce Network, funded by the Government of Canada's Sectoral Workforce Solutions Program. A reminder that this session today will be recorded, and to please keep your microphones on mute during the presentation. Please hold all questions as well until the end of the presentation, and feel free to add them into the Q&A tab on the bottom of the Zoom dashboard at any time during the session. We'll start the Q&A with any questions put into the Q&A feature, as well as take then questions from the attendees. So I'll now turn it over to Kamlesh and Melissa.
Great. Thank you, Don. And hello, everybody. I'm so pleased to be here and talk about psychological health and safety. Our team's been focusing on supporting leaders and teams and organizations on how they can integrate psychological health and safety, and especially in healthcare workplaces. So I will begin by also sharing about the benefits of ensuring psychologically healthy and safe workplaces for healthcare workers, and then going through the psychological health and safety toolkit that Don introduced earlier. And I'll give you a few examples of some helpful resources just to get you a little bit more familiar with them. And then I'll turn it over to Melissa, and she's going to present on the burnout toolkit and also share some helpful resources. And then we'll go to the Q&A. So as Don mentioned, we encourage you to add your questions throughout into the Q&A feature. So what is psychological health and safety in the workplace? This is the systematic support that's provided in an organization and within teams. And the purpose is to actively prevent and minimize the risk of psychological harm from work-related causes. And it's also to help promote mental health. So psychological health and safety, it's embedded in the way that people interact with one another. It's also the way that the working conditions and the management practices are structured, whether it's in the organization or at the team level. Psychological health and safety helps address the root causes of psychological stressors. So some examples of these stressors include high workload, lack of control over work, or relationships with colleagues or managers, and job insecurity, to name a few. And on the next slide, I'm going to highlight some of the benefits of psychological health and safety. So there is a strong business case for implementing psychological health and safety in the workplace. Clinicians report high rates of fatigue. And though burnout and stress are not new issues, it's now recognized that clinician health mediates patient health and organizational outcomes. Psychologically healthy and safe workplaces can lead to a variety of benefits, and it's not only for healthcare workers, also for healthcare organizations, for patients or clients accessing care. So there's a number of benefits on the slide, and I'll just mention a few that we see in a healthy workplace. We see enhanced workforce well-being. We see improved morale and relationships and a sense of purpose. And we also see improved recruitment and retention, just to name a few. A psychologically healthy and safe healthcare environment also leads to improved team learning, improved team performance, and continuous quality improvement environments. So most of these findings come from the National Standard of Canada for Psychological Health and Safety in the Workplace. We also call it the Standard. And so let's take a quick look at the Standard. The Standard, it's recognized as a leading practice by Health Standards Organization, and it was developed back in 2013, and currently it's undergoing a review and an update. So the standard identifies 13 psychosocial factors that can affect psychological health and safety in a workplace. And it also now recognizes a 14th factor, which are factors that are specific to each industry. So for example, after further research, the MHCC and Healthcare Canada identified 2 psychosocial factors that are especially relevant to healthcare. And the first one is protection from moral distress, and also support for psychological self-care. So for easier understanding and implementation in healthcare settings, the MHCC and Canadian Health Workforce Network, or CHUN, clustered the psychosocial factors into 7 themes. So let's look at those 7 themes. Nurse leaders and organizations can identify from any of the 7 psychosocial themes to help focus the development of your plans to improve workplace processes and practices and activities, really taking a systematic approach that will better support the psychological health and safety of your teams. And I'm just going to highlight 2 themes that link back to the examples that I'll be sharing from our toolkit. So the first one is organizational and team culture. So many initiatives to integrate psychological health and safety in workplaces involve understanding and changing the organization and team cultures. So this includes shared norms and values, beliefs, which are behavioral and problem-solving cues, and they must be based on respect. In some ways that leaders and organizations can take action include providing staff with psychological with improving staff engagement, staff involvement and influence, also staff recognition and reward, and ensuring civility and respect in interactions and in the workplace. The other theme I want to mention is the psychological protection. And this is where staff psychological safety is promoted and it's safeguarded and stigma is effectively addressed. So in order to support leaders and teams in your efforts to embed psychological health and safety in healthcare environments, CHUN and MHCC developed the Psychological Health and Safety Toolkit for primary care teams and training programs. And to learn more about the development of the toolkit, please refer to the article published in Healthcare Management Forum, and the link has been provided in the chat. So we launched the toolkit in March 2024. I encourage you to scan the QR code to access that or click the link in the chat. The Psychological Health and Safety Toolkit has over 125 evidence-informed resources. So you're going to find resources that are talking about team-based activities or policies or practices so that you can promote psychological health and safety, whether it's in the workplace or a learning environment with trainees. The toolkit is broken down into 7 psychosocial themes, and we just discussed those. So for example, if a leader might be looking to provide a more compassionate leadership approach to their team, then they can review some resources under the clear leadership and expectation theme. There's also definitions included, so that really depends on what your needs and focus are in your organization or in your departments. So to facilitate the search for suitable resources, you'll be able to easily find these resources using any of the 10 filtering options. They're included on the left-hand side. So you can search by any of the 7 psychosocial themes you may focus on. You can look at the intervention level you're interested in. Are you looking to make changes at the system level, the organization, team, or individual? You can also select by audience. So depending on your role, you can search by healthcare worker, a trainee, leader, trainers. We really want to help customize the search for you. And also you can look at the filter for settings. So do you work in a hospital? Are you in long-term care, community care, primary care? You can select as many filters as you like, and then you click on Show Results. And then you'll see the resources are displayed as shown on the right-hand side. And then if you want more information, just click Read More, and you'll be able to also access the resource. So now that you know a little bit about the toolkit, I'm going to share with you a few nurse-related resources that we picked that we thought would be helpful to start off. So this is the Resilience Toolkit for Nurse Leaders, Interventions to Build a Resilient Culture. And this builds on the relationship between factors that affect clinician well-being and resilience model by the National Academy of Medicine. And it also looks at the framework for improving joy in work by the Institute for Healthcare Improvement. So there's a variety of resilience interventions that would provide nurse leaders the option to develop options on how to develop a culture of health and well-being. There's different tools that could meet the needs of an individual or a team or organization based on your context. So this includes, the leader first assessing and then diagnosing and selecting solutions, and then to best build resilience across all the organizational layers. So for example, we hear from Carrie here, who's an Ontario nurse practitioner, and she says, we developed a curriculum for nurse practitioners who will be delivering primary care in long-term care settings. And the psychological health and safety component was an actual piece of our final module. And you can see the chat for the link to the learning if you're interested. The toolkit also talks about nurse resilience at different levels. So leader resilience development, nursing resilience, student focused interventions. So I could talk a little bit more about that later if folks are interested in hearing more. We also have QR codes for each of our resources we're sharing. So you can scan that to go directly to the resource. But our toolkit, the website is also teamhealthandsafety.ca. So this is the long-term care best practices toolkit developed by the Registered Nurses Association of Ontario. It's based on this organization's healthy work environments best practice guidelines. They relate to developing and sustaining nursing leadership and also preventing and managing violence in the workplace. So there's evidence-based tools, there's best practice guidelines on many issues such as interprofessional collaboration, conflict management. There is a interprofessional program that's provided online. And then there is a appendix that talks about promoting respect. And so in addition to respect in terms of addressing conflicts and de-escalating them, there's several actions that can be taken to integrate psychological health and safety. So looking at the acronym for respect, recognize the inherent worth of all with whom you work, eliminate derogatory words and phrases from your vocabulary, speak with people, not at them or about them, practice empathy and walk a while in others' shoes, earn the respect of colleagues and coworkers through your behaviors, and consider your impact on others before speaking and acting, and finally, treating everyone with dignity and courtesy. So in the next example, the culture change toolbox. So much of what we've shared so far relates to changing culture. So while this resource is not specific to nurses, the toolbox offers a framework for culture change. And the toolbox has a guide. It outlines 6 steps for changing culture, especially in healthcare. So the first is to engage people. So engaging the people that will be impacted by the improvements that we need on board to help implement the changes. Who are the champions? So bringing folks along through the entire initiative. Secondly, laying the foundations, looking at the governance for such an initiative or having a steering committee. Third is assess the current state, collecting data, identifying the issues, understanding them, and involving staff within that identification analysis. Fourth, identify and analyze the opportunities. Fifth, choose the tools that are going to help to monitor and evaluate the intervention. And then finally, test the changes. So also this toolbox introduces key components of a strong culture, such as what they call just culture. Which is an organizational and team culture in which everyone learns from mistakes and works to change the system to prevent the same event from happening again. Some examples of how-to strategies include filling in incident reports or bringing up the infrastructure issues or process issues at team meetings. And so these are ways to change the person and not blame the person. And finally, another final example is the toolkit this is developed by the UK's National Health Service. And it explains 3 different intervention levels to support psychological health and safety. So I'll start with the secondary interventions. This focuses on reducing the effect of a stressor. So how staff are responding to an issue. So for example, making staff more resilient.
I'm going to stop you right there. This isn't what we discussed. You've gone over your time. So I'm going to take over from here. Michaela, if you can switch to the next slide. So the Health Worker Burnout Toolkit was funded by the Canadian Institute of Health Research. It's part of the operating. Hussam, I see your hand up there, but we're saving questions for the end.
Sorry, Melissa. To be honest, I don't really feel comfortable the way how you took off the presentation. I know even Kamlesh has turned off her camera. So if you give her like 2 minutes, like to wrap up her part, that would really be appreciated. Thank you.
My apologies, Kamlesh. It's been a rough week. We've had a lot of staffing shortages. I interrupted you. I'm sorry. I take ownership over that, and I apologize. I hope that you'll come back and finish your section.
Hi, everybody. I just had to turn my camera off. I thought I was doing the right thing. I didn't expect to get interrupted like that. But thank you, Sam, so much for speaking up for me. And thanks for your apology, Melissa. It's made me feel quite uncomfortable, but I appreciate it was acknowledged that the interruption was inappropriate. And yeah, I will do my best to finish off. But yeah, just acknowledging I'm finding it hard to bounce back quickly. Okay. Yeah, so as I was saying, the tertiary intervention, it focuses on helping staff cope with the consequence of a stressor. So I guess I'm kind of relating to that right now. So for example, giving access to employee assistance program. So primary interventions focus on the root cause of the stressor, and they're going to focus on themes like leadership, culture, workload, teamwork, physical environments, governance, kind of the themes we were talking about. Examples would be developing a shared team objective, peer support programs. There's also a toolkit the toolkit explains the AIM approach. So analyze, intervene, and then measure, and talk about supportive interventions and corrective interventions, and not to blame or punish folks. So if there is a single incident, a supervisor can do an informal cup of coffee intervention, but if it seems to be a pattern, then it's worth having an awareness intervention. Yes, so thank you, Melissa.
So I just want to let everybody know what you just witnessed was a skit. And it was to give you that visceral reaction of when people experience incivility. So we planned this. Melissa's a really wonderful person, and as is Kamlesh and Hussam. And just wanted to let you know that no team members were harmed in the conduct of this webinar. So we apologize a little bit for causing you stress, but we wanted to create this kind of experience for you then to reflect about how you feel. So on the next slide, we have some questions that we would like you just to take a few moments, and we see lots of surprises from everybody. So on the next slide, we have a few questions just for you to consider. And oh, sorry, we don't have that on the slide that I have. So just give me one moment. So a couple of things that we wanted to just ask is, how did you feel when you were watching and listening to this situation unfold? Have you experienced something similar at work? Have you witnessed it? And how did you feel then? And what could be done to prevent or avoid this from happening in the future? What were some of the things that we tried to kind of role play here in terms of having somebody interview them, highlighting the importance of speaking up, highlighting the importance of having someone come in and recognize that what had happened to them is like a microaggression or an incivility, and having the person who enacted that microaggression give them space and time to apologize and provide a little bit of context. So you need to support the person on the receiving end of the microaggression, but it's also really important to debrief with the person who engaged in the microaggression. Everybody in this situation needs to be in an environment of psychological health and safety to address what has happened. And so if you wanted to just, add some of those comments into the chat, that would be really great. From a leader perspective, it's really important for those in leadership positions to intervene. They may not be there, but for them to kind of create a space for psychological health and safety. They need to model respective behaviors. They need to clearly communicate with the members of their team to ensure the understanding of the roles and expectations. At what point in the slide deck, does someone finish? Does someone take over? And again, just to remind everybody, this was a skit. But also from a leadership perspective, to ensure that, policies and procedures on the books actually get reflected in the practices that promote and safeguard psychological safety at work, and to take actions when things go awry or go off the rails, in the way that Hussam did in our skit today. So I welcome everybody to add their comments and questions and reflections in the chat. And with that, I'm going to pass to Melissa, who will now actually start the section on another toolkit that we've created. Over to you, Melissa, who is, again, everybody, a really wonderful person.
Thanks very much, Ivy. And I won't speak on behalf of Kamlesh, but my heart was racing before the slide switched to the one that I knew I was supposed to intervene. So even though I knew it was a skit, it still elevated my heart rate and made me feel uncomfortable. So I appreciate everyone's time and space as we kind of worked through the skit. We just wanted to do something pretty meaningful and powerful that will make this webinar memorable, since there are so many webinars out there. So our first goal in developing the Health Worker Burnout Toolkit was to really understand the factors that facilitate or hinder burnout among Canada's health workers. And our second goal involved identifying and evaluating a set of evidence-informed strategies. And I always joke with Ivy that my eyes are still twitching from searching all the different academic and gray literature for more hours than I'd like to admit. And when developing the toolkit, I want you to think about Netflix and all the movies and TV shows that you have to choose from. So when developing the online platform, we envisioned it being a fit for purpose experience so that different health workers, teams, and organizations could come and choose resources based on what makes sense for their situation, recognizing that the context of where you work plays a huge factor. So we'll go to the next slide. So this is a free bilingual platform, and it aims to provide resources that range a variety of healthcare settings that you can adapt and adopt for your situation. And the goal is to provide strategies that improve the mental health of healthcare workers. And we intentionally organized it at 4 different levels. So we have system level interventions that target policies more at an association or union level. And these include things like collective agreements, government action, or advocacy. The organizational level focus on policies within an organization. So things like leadership development, training opportunities within the learning environment. And then as we go to the next slide, team level interventions focus more on peer support, mentorship, and leadership within a group setting. And we were very particular about which individual interventions we chose. We recognize that in healthcare specifically, a lot of things are at system level issues. So we don't want to put the onus on nurses or healthcare professionals to quote unquote fix themselves. So we really tried to choose interventions that focused on worker empowerment, changes in work culture. So like Kamlesh mentioned with the culture change toolbox. And so we didn't include any single interventions that just said to nurses or nurse leaders, like, this is your problem, you fix it. That was not the intention of the individual section. So I want to provide a few examples of things that are relevant to nurses and nurse leaders. So on our next slide, we have a system level intervention. And although this is an American resource, we feel it's very applicable to the Canadian setting. So the Magnet Recognition Program is considered the highest recognition for a hospital nursing department. And there's a real big growing body of literature that indicates that Magnet organizations enjoy lower nurse dissatisfaction and nurse burnout. They have higher nurse job satisfaction and lower registered nurse turnover. So definitely something to keep in mind. There's a lot of elements within this Magnet program that could be adapted and adopted to a Canadian setting. The next intervention that I wanted to share with you is at an organizational level, and it's called Mattering. So Mattering is about adding value and being valued. So we argue that healthcare organizations have a fundamental obligation to mitigate and prevent the costs of caring. So there's a lot of moral distress and secondary traumatic stress that comes with the job. And so well-functioning moral communities have strong support systems, inclusivity, fairness, open communication, and collaboration. And it's really important that we're able to protect our members. So leaders of moral communities are responsible for implementing systemic changes that foster mattering among its members and attend to the problems that cause moral distress and burnout. So a lot of the issues when it comes to recruitment and retention, a lot of nurses and nurse leaders don't feel like their work is being valued. And that goes along with the increase of workload. So mattering is something that we would like to recommend at an organizational level. The next one is a team level intervention, and it's called a wobble room. And it helps create a space for healthcare workers to unwind and connect in a quiet environment. So it's a wellness intervention designed to guide staff through unpredictable times. So there are cultural spaces for patients. However, it's important to dedicate space for staff to de-stress. And the goal is to have something for everyone. So whether it's a computer for personal use, a coloring station, puzzles, books, a yoga mat, a lounge chair, or just inspirational images and messages on the wall, all of these things combined just show the staff that they're cared about and that they have a space to go to, especially after a traumatic event. There's many more examples that I could share with you, but I really want to save space and time for us to have a rich dialogue. I just want to highlight one more example. It's one of Ivy and I's favorite examples, and it's called Getting Rid of Stupid Stuff. The acronym spells the word GROSS, and it involves looking at your day-to-day tasks in an effort to remove unnecessary tasks that no longer serve you or your team members. So keeping in mind the getting rid of stupid stuff, that was a great one at a team or an organizational level. So we'll move to the next slide. So as we've seen, the quality of healthcare services is impacted by the psychological safety and well-being of health workers. Everyone has a key role in creating psychologically healthy and safe workplaces. Teams, learning environments, especially healthcare leaders, have a huge responsibility. So we invite you to explore both the toolkits. The links are posted in the chat, so you can kind of browse at your own convenience. And on the next slide, we just have a few references in case you're interested. And then I will pass it over to Dawn, who's going to facilitate our Q&A section.
Thank you, Melissa and Kamlesh. Excellent presentation today. And I'm just going through some of the responses in the chat as well as some questions posted into the Q&A. It seems like the skit as a vehicle to introduce this content is having a significant impact. Could I maybe ask the group or the panel, just to get the ball rolling as far as like the Q&A, the reason to not include like a disclaimer before to say that there's going to be a skit. I would believe that there was probably discussion about how it could be introduced so that it's not necessarily, like a triggering event for those that had been experiencing incivility or bullying. But could you give us a little bit more information about the decision to deliver the skit, how it was delivered, and just kind of went into the design of the skit itself, because I think it really hit your intent, but sometimes there's the unintended impacts as well, and that's kind of what I've been reading in some of the chats. It sounds like some people were really not necessarily triggered, but right there they could really relate to what was done. And so overall, very well done with the skit. But could you give us more information about the planning and the development to integrate it into the discussion as it was today?
I think we wanted this skit to reflect reality. Oftentimes when microaggressions happen, they happen so quickly that you almost are in shock and either don't respond or don't know what to say. So we wanted this skit to reflect what actually happens in the workplace and to recognize that sometimes someone speaks out and says something inappropriate and everyone's, I don't want to say deer in headlights, but sometimes everyone's just in so much shock that actually happened that they don't know how to respond. So we wanted everyone to experience it in real time. I think it would have been different had we given a disclaimer and people knew it was coming. So I'll pass it over to Ivy.
Yeah, thanks, Melissa. So we did this skit in another webinar when we were just talking about the psychological health and safety toolkit, and I'm not sure how it arose out of the situation. I think, as a teaching device, skits, can be really helpful. We wanted it to be realistic, and we wanted people to experience that visceral reaction. We think that people would remember the webinar and remember the resources and remember how it was resolved. I think what happens when we experiencing these things, my natural reaction is, there's fight or flight and freeze. I'm a freezer. I freeze in those circumstances. And I'm just like, whoa, what just happened? And so it's, how do you move from that freeze mode to the act mode? And that's what we need everybody to do, because when we talk about people in leadership positions, everybody can kind of lead from where they are. So people can be the intervener, like Hussam did. And also, you also want to respect the person who experienced the microaggression, of course, but also the person who leveled the microaggression, or in this case, seemed pretty macro to us. And so we wanted to be able to kind of make sure that everybody saved face and get to give an example. But absolutely, we appreciate that. This may have harmed people. A disclaimer slide at the beginning probably would have been helpful. Might have cued people into the fact that there was going to be this skit. And so, yes, we understand. And so we do apologize if people were strongly triggered by this. We do hope that it triggered a learning, and we hope that people can use a skit like this in their activities, and to talk about what are the types of tools in the toolkit that can be used to create better psychological health and safety as a proactive strategy, and to deal with burnout from the burnout toolkit resources as a reactive strategy to the circumstances that we're in.
Thanks, Ivy. And Hussam, you had your hand up, and then we can go to the Q&A. There's a number of questions starting to queue up.
Yeah, thank you so much, John. I think this is a great way to remember healthcare workers about our moral engagement to our colleagues, because if we are not conscientized, and just we're using the word of Paulo Freire, we need to conscientize people that these practices are unacceptable. Even though we see in the literature there is a lot of research until today that they talk about incivility, etc., but there is no concrete actions toward tackle this issue. And I think this is very important. And healthcare workers are the backbone of healthcare systems. So we need to support ourselves and to speak up about our colleagues, and without fear. So thank you so much, Don, for raising this question.
Great, thanks, Hussam. We can now go to the Q&A. The first question is from Sarah Walker. How has the toolkit been received by organizations in terms of implementing and finding time to allow how nurses participate in psychological health and safety actions in the wobble room, for example? Would anyone like to tackle that one?
I can tackle that one. So we worked with a healthcare organization in Ottawa, and we were kind of like their personal shoppers. So we listened to what their concerns were, and they highlighted a few concerns. And so we went into the toolkit and provided them a short list of 5 interventions that we thought would be helpful. They ended up choosing one called commensality groups, where you get together with colleagues that don't necessarily work in your department, and you go out for a meal and share a lunch with them, get to know them on a personal level. That one was very effective because we had a lot of issues with staff feeling disconnected from different departments. The other one, they also adopted, it was kind of like the wobble room. Again, these interventions are just to kind of spark ideas. So you don't have to take them exactly as they are, but they did take elements of the wobble room, and they created a space within their organization where staff could go to relax and unwind. They purchased a whole bunch equipment, like they have a light for in the winter with seasonal affective disorder. They put some literature on the bookshelf. They added, I think, a stability ball and some fidgets for their staff to engage with. And it was very well received by the staff. The staff felt like they were being valued and cared for because these were their concerns that they brought up. So to see those concerns actually turn into action, it was very well received. But again, I know, Sarah, what you're talking about, it's very hard to dedicate that time. So even if you create a space, do the staff even have the time to use that space? So that's one challenge that we're definitely cognizant of.
Great, thanks, Melissa. Our next question is from Kirsten Smith. How have these tools been implemented, and how can we ensure the resources can be actionable? Have you as you have mentioned that you tried to put the focus less on nurses, but more on the system level, how can this occur? So would someone be able to respond to that?
Sure, I could start. So in terms of the toolkit, we've used it as also a tool, something practical for organizations to have, to be able to look at their contacts and see what's relevant to the area, their goals, their objectives, and then what resources would help them in that. I think over the last year, our organization at the Mental Health Commission of Canada, we've been focusing on increasing awareness, dialogue, conversation, and an approach that's sustainable to talk to organizations about psychological health and safety. And we know that healthcare organizations, leaders, and folks have been talking about mental wellness and mental health, and there have been various initiatives, and some are at different levels, right? Some may be focusing on individual level interventions. And so we've really tried to increase the conversation to look at the different levels of intervention. So while I see the question is talking about saying, well, we're less focused on nurses, but more on the system. It's not in the sense of less on nurses, or it's more about that the onus is not on the individual to solely to have a great impact on changing the culture. So if you look at our skit, that can be really difficult in terms of the way we approached it with the Hussam stepping in and then the apologies and then me being able to try to bounce back and finish my presentation, just kind of role modeling an approach that might be really difficult for an individual to step up or for the folks to receive. And when you have a culture within a team, and it can be a small team or it can be a department, or it can just, then spread across the organization where we all have the same language, understanding, definition of the psychological health and safety. What are the behaviors that support it? And what are the behaviors that cause harm? And what's acceptable and how we can move towards more acceptable behaviors. I think that this is what we're looking for. So it would definitely have an impact at the individual nurse level or other providers, but we need to, open up strategies that are beyond just an individual focus. So this is why we are trying to talk about the system level or organization or team level interventions.
And Ivy, would you like to add to that as well?
Yeah, if I could add, I think it's important for staff engagement for them to see that the interventions are not just focused on them. I think it's important for them to be empowered to do, the types of intervention that Hussam did, because culture is just the accumulation of all of our interactions, all of our individual actions together, and those exist within a structure. So I think, again, it's important that there be a multi-layered intervention strategy. When Melissa talked about one of the locations, they took 5 interventions and they focused on different levels. And what that did was it engaged some people who were really very anti-individual level, and so that they could see that they could be part of more systemic, more organizational levels. And I think, and I'm not sure that this is in the toolkit, but, just to try to figure out how you intervene in interventions. And again, if you're a natural predilection, and nurses are all very caring people, and you tend to be kind of like self-sacrificing, and you tend not to be doing, things like that. And so you have to think about your colleagues as you think about your patients, that you need to care for them as well as you care for yourself. Some people had said about, creating more civility in meetings and things like that. And they used cards, like in a soccer game. And so people were given a yellow card or a red card. And so you didn't have to say anything per se, but all you had to do was just kind of hold up a yellow card to say, wait a minute, something wasn't right here, right? Or a red card that, somebody needs to have a bit of time out just to kind of, figure out what it is and where they're coming from with this. But again, multi-layered interventions are really important for people to be engaged in it and not feel that you want to balance off that feeling of being empowered to intervene, but not feeling like you have to change everything yourself.
Thank you, Ivy. Our next question is from Tyler Levitan, and it's directed towards Kamlesh. Around the CSA standard that you mentioned, 2 additional psychological factors you'd recommend. One, protection from moral distress, and which was the second one? Could you speak briefly about these additional psychosocial factors?
Sure. The second factor is support for psychological self-care. So in terms of the moral distress, it's where, supporting the individual healthcare worker to be able to, work in a way that aligns with their values. And so sometimes the decision making can happen that is within the constraints and the limitations. We saw a lot of that happening during the pandemic when there was limited capacity, limited resources. The need was so great. And so there was a lot of moral distress from healthcare workers who have taken an oath to provide the highest quality care, to provide the best care that they can for their patients. And when there is a gap in them seeing that is happening and they are carrying out duties that contravene that commitment, then it can cause moral distress. So there are resources and examples of what organizations can do to help support individuals' moral distress through various supports that are provided, whether there could be an ethicist to provide guidance to staff about decision making so that they're not on their own, or there are specific policies that are there to guide the decision making so that it's not on the individual to enter into a moral distressing decision making, but they are following the organization's policies and practices. In terms of the support for psychological self-care, so this is where the organization can put in place practices that can support the individual. So, for example, we know that during the pandemic that there was, as I said, the limited capacity, but greater need. And so staff were really not able to look after themselves with limited time off or for vacation or leave and whatnot. So there's just accumulated effect, and it's difficult to look after their own, their psychological safety and health. The organizations can put in place a champion or a person that's going to lead the psychological health and safety in an organization, support units or teams or managers to be able to come into an area and help facilitate conversations about understanding where there are gaps from the staff, and then together formulating what would help them to be able to look after themselves better. So I think working with staff closely to understand from their perspective and solutions that they feel, would directly address some of the pains, sources of pains at work.
Great. Thank you, Kamlesh. The next question is from Sabrina Gill. How did you embed anti-Indigenous and DEI into the context of psychological health and safety in the toolkits? And I guess that's open to anyone on the panel here.
In terms of the psychological health and safety toolkit, We did include a filter so that folks can filter specifically in this area. So we have a filter called identities. I wasn't able to go through all the filters, but that's one of the 10 filters. So folks looking to search more specifically on resources specific to certain populations, whether it's Indigenous population, 2S LGBTQ+, or immigrant, refugee, ethnocultural and racialized populations. We have a number of resources that speak to supporting folks to have inclusivity for all. So for example, there's a resource about practical lessons for teaching about race and racism, successfully leading free, frank, and fearless discussions. So I encourage folks to use that filter to learn more as well what's there. Thanks.
And Ivy?
Yeah, and just to add what Kamlesh had expressed, when we were doing the searches, that was very explicit in our mind. We wanted something that took into consideration issues around gender, racialization, Indigenous identity. We incorporated a couple of additional resources that were recommended by teams that we worked with the psychological health and safety group. And but I have to say that is not something very popular. So not popular in the sense it just is not very, you don't see it very often. And so that is a bit of a challenge. So we would want to encourage everybody when taking these resources to have an explicit EDI lens in mind. One of the other things that I'll mention is that one of the other things that is not just about people's identity, in terms of gender and where they come from, is professional identity. And so a lot of the microaggressions can be across professions. And one of the big lessons learned for us when we were doing the Teen Primary Care Initiative is how many professions don't know about what each other does. So they have sort of just a lay knowledge about what each other does. And so they have very stereotypical views of nurses, of midwives, of, personal support workers, what practical nurses or psychiatric nurses do. Like some people just don't even understand those distinctions. And so in addition to having an EDI lens, part of that is also professional identity. So I just wanted to highlight that.
Great. Thanks, Ivy. The next question is from Michaela Poole. Are there any resources for addressing a situation after when you aren't able to speak up directly? And so, for example, on a webinar where there's no platform to actually bring forward the concern. So when there's no tool to direct it or to address it initially or directly, how do you go about, after the fact?
Yeah, point well taken about the, speaking up during the webinar. I think, some people used the reactions button. Some people were feeling pretty angry about that. Some people put things into the Q&A and some people put things into the chat. But there wasn't really an opportunity for anybody who is in the listening audience, because it's a webinar and we don't see you all, to intervene. But we did have Hussam in his intervener role. And we also appreciate, the dynamics, there are gender dynamics, Hussam identifying as a man, intervening in a conversation with two people who identify as women. We do appreciate that. And we would have switched things around, thinking about those things. So point well taken. And again, we wanted to do the skit for effect. We wanted that visceral reaction. And I appreciate that triggered people as well as the people who were actually doing the skit, as Melissa and Kamlesh and Hussam were saying. I was also sitting there, when you're knowing that it's coming, your heart races a lot. And when you're experiencing it in the audience, we wanted to kind of highlight and make this memorable so that you would really look towards the tools to address these types of situations, which are unfortunately all too common.
Thanks, Ivy. The next question is from Erica Vogel. Or Hussam, would you like to add to that before we jump on to the next question?
Yeah, just quick point. It's like wherever we are behind the screen or in person, we need to have the courage to speak. So I know like most of conferences or webinars are online, but if we are in person, we need to speak up if you have the courage, and also we think about our moral imperative toward our colleagues.
Thanks, Hussam. The next question is from Erica Vogel, and it's open to all panelists. What is your message or recommendations on getting the system and operational levels to take advantage of this standard and best practices for implementation? So what's being done, or what can you do to get this actually, integrated into system level or operational levels? Or how are you getting it into system level or operational levels? What's currently being done for integration?
I can speak to some of the other sites, like Melissa was working, directly with one site, and some of our other sites, had varying degrees of engagement with this. And I know out of our work, and Melissa put into the chat that even when you build these toolkits, right, where you have this one, even if you build it, they may not come. So it's in part why we're doing these webinars, to get, some of the examples from the toolkit out and open. And it can seem very overwhelming for folks, like, oh, great, it's great that there's 125 resources, but oh my God, there's 125 resources. Just filter and start with something. Start with something, whether or not it's like one of our favorites, getting rid of the stupid stuff, and calling it your own. Like, it's about not just adopting things, but adapting it to your particular setting. And one of our clinical settings did that. And I think that enabled more engagement, because it wasn't just off the shelf plug and play. It was, oh, that's really interesting. How could we integrate that to kind of meet the needs of our organization? Pretty much all organizations, because of accreditation, collect data on what's happening with their workforce. Look at those data to try to figure out how you could target and tailor interventions to what might be some, warning signs in your organization. And, engagement with others, like creating a committee, a paid committee, like so that the time that you spend on that committee is paid to like improve the situation, is an important investment. And this is the message that we give to health leaders, that the time you invest in the health and psychological safety of your workforce is, a really good investment. You get a huge return on that. So, making sure that you bring people together, having them feel engaged, and it means that you empower more than just one individual. You empower several to kind of bring issues to the fore, some of which may have arisen from the surveys, and some of which you may need to just have a good ear on the ground, through your union representatives, for example. It's important to kind of have those good liaisons with folks representing you. So yeah, I would definitely suggest that.
Thanks, Ivy. There's a couple more questions in the Q&A, and then I see in the chat that a couple of web or email addresses were put in to Kamlesh, and I believe to I'm just looking for the other one. There was a second one for if there are additional questions after the fact. Sometimes questions don't formulate until later on, but if you do have follow-up questions, do look in the chat for a couple of email addresses there at the bottom of the chat, so you can send those emails forward to the panelists. Our next question is from Katrina Stephenson. From a team and individual level, how has your team seen peer support being utilized?
I can speak to this one. So one of our organizations, with the connection circles and sharing a meal, they did informal peer support at that one, and they actually bought a really cool deck of cards called Cool to Connect, and they would use those cards to not only talk professionally about things that are challenges they're experiencing at work, but to also get to know each other on a personal level. So I think the informal peer support has been fairly effective with the teams that I've worked with. And I know there's lots of organizations that have more of a formal system, but from what I've seen, the informal peer support has been the most helpful.
I can also jump in as well, just hearing from folks as well, that a team can provide a regular recurring opportunity. It's optional for folks, for team members to come together and have like a half an hour or an hour, and they can discuss and share. But I think it's also about identifying as a group, like what is the objective of them coming together to support each other as in a peer support program, so that it leaves people with some actions they can take or some helpful suggestions or advice that is going to support them, rather than people feeling that sometimes it's not successful if people feel like, well, we've done that and it just becomes really a lot of emotional dumping. And so then that becomes more of a burden, and people are feeling more a burden by hearing this information. So so it's just different options for different folks of what's going to meet their needs.
Thanks, Kamlesh. And our final question goes to Charlotte Ross. Are there any initiatives underway that have these safe workplace standards integrated into the accreditation process in healthcare? So are there any initiatives that anyone on the panel is aware of about examples of actually building these workplace standards, integrating them into the processes?
I don't have any specific examples, but I know that folks at the Health Standards Organization Accreditation Canada, I think they're very interested in looking at interventions because they do the Pulse survey, and I think they are looking at doing that next step. The Pulse survey with many of the organizations that we worked with for the burnout toolkit, figured quite prominently, as well as the Guarding Minds with the Mental Health Commission. And yes, I think that we need to move from surveys into targeted interventions, action, evaluation, and then circulate all over again, for a cycle of continuous quality improvement would be great.
Great, thanks, Ivy. And one quick comment from the question or Q&A. Just from Aaron Hertz, the CNA Stellar certification includes the standard of practice environment. Nurses' working conditions are positive and safe. So that is something that is also in the Stellar certification done by the CNA. So that's a good inclusion. And I just wanted to make sure that it was somewhere here. Then that brings us actually to the end of the webinar. Thank you to all of the panelists for such an engaging presentation and thought-provoking and stirring and triggering and all of those good things that will make this a memorable webinar. As I had stated before, if there are any follow-up questions that weren't able to be discussed, please take a look in the chat for a couple of the email addresses to pass those on. Do please join us for session 2 and session 3 in June and in September. Amazing presentation, amazing engagement. Thank you to all the panelists and all the attendees. Enjoy the rest of your day, and thank you for attending. Take care.
Thanks, everyone.
Thank you, everyone. Bye-bye.
Thanks, John.